interesting for you to know about. I would first of all say that I'm not an expert in all of these topics, and that it's not all my research, but some of it is, and I'd be happy to take any questions or expand as I go along. So if anything's not clear or you want me to give any further detail, then please just put up your hand and interrupt me. I'm quite happy to be interrupted. So an overview of what I'm going to talk about in 10 minutes. I want to touch on the point that this gentleman made about the international collaborations that are happening. I want to talk about the genetic study that's already been mentioned. I want to talk about an exciting new imaging study. I want to talk about a study that I'm specifically involved with at the Dementia Research Centre that involves lots of different things, imaging, psychology, and also the importance of cerebrospinal fluid, the fluid that bathes and surrounds the brain. So first of all, I want to draw your attention to this paper, which we can give to people afterwards if they want it. But this is a key paper. The reason it's key is it's a paper that was written following the working group for PCA who met for the first time in July of last year. Now, collaborative research has been hugely successful in other disease areas, particularly other neurodegenerative diseases, Alzheimer's disease, Huntington's disease. So instead of research groups working in isolation, we're talking about international research groups coming together, pooling their resources, sharing their data, and getting better and more useful results for people. And I'm glad to say that this is now happening in PCA. So the first meeting happened July last year in Vancouver, formed of 38 clinicians and scientists from 23 institutions, 9 countries. And the first aims are to standardise how is PCA diagnosed, what are the clinical criteria, what tests we should be doing, so what types of MRI we should be doing, what types of memory testing can we do across the board, and also what biomarkers should we be collecting. Now, what is a biomarker? That's any piece of information that we can collect from an individual that might tell us something about the disease process. So that could be a urine sample, it could be a blood sample, or it could be a test, like the test that Tim's been doing. And also, hopefully, it will provide a platform for collaboration. And indeed, since July, it already has started to be a good platform for a very useful collaboration. And the first main study to come out of this is looking at genetics. So we have agreement from various other centres in 4 countries so far to donate blood from their patients so that we can look to see if there is a genetic signature for PCA. And UCL is going to be leading on that. There's a very exciting imaging study that is a collaboration between the University of California in San Francisco and UCL. And this is looking at the function of the brain. So we're very good, or reasonably good, at looking at the structure of the brain in MRI scans. So we can get these beautiful pictures of the brain on MRI and look at which parts are shrinking. But we're not so good at looking at the function. So looking at which neurons, which nerve cells, and which network of nerve cells are not working so well. And these types of scans are very useful for looking at where abnormal proteins are laid down, which nerves and network of nerves are not using as much glucose. And there's already been some very interesting results from this. One of the PhD students, Dr. Lehman, who's actually a postdoctoral student now, is coming back to work in the DRC with us. So I'm very excited about that. This is a study that I'm directly involved with, which is just about to start at the Dementia Research Centre. It's looking at all patients with young onset Alzheimer's disease. And as doctors, we've recognised for some time that people who get Alzheimer's disease in their 40s, 50s and 60s look, when we examine them, very different from people who develop Alzheimer's disease later on in their 70s, 80s, 90s. And we've been very keen for some time to look and see what these differences are, and get some really detailed information on this. How is the imaging different? And PCA is a good example of that, and we will be recruiting people with PCA to this study. So it's due to start, still under ethical review, but due to start later on this year. We'll be doing scanning, we'll be doing more detailed neuropsychological tests, we'll be doing smell testing, we'll be doing detailed questionnaires, sleep studies, all sorts of things. So it's going to be a huge amount of work, and it's going to be followed up for many years. So some of you may be involved in that. We're also recruiting healthy controls as well. I'm not allowed to advertise, but we're recruiting healthy controls. And then, lastly, this is another area of my own research. I was looking at cerebrospinal fluid. Cerebrospinal fluid is the fluid that surrounds the brain and the spinal cord, and it's a bit like the urine of the brain, if you like. It's produced deep in the brain and it circulates around. And it's an area that's been neglected, particularly in PCA. Hugely valuable resource. It's in direct contact with the brain, so it must tell us something about the disease biology of the disease. So why is it likely to be useful? Well, mechanisms of disease. It might help us aid diagnosis in future, and if in future 5-10 years down the line there are treatment trials of new drugs, it might allow us to determine how effective these drugs are they working or not. So I'm going to be collecting spinal fluid and doing lumbar punctures in people as part of this research. So you may be approached about that in the future as well if you were ever involved. So that's a summary of what's happening at the DRC. So in summary, very active area of research. It's now international. It's involving multiple centres and involving multiple different research mediums. No treatment trials at the moment at the DRC, and there will be opportunities for people with PC and those without to be involved in research.
With this cerebrospinal fluid, it obviously can't be used now as a direct this is PCA because we've seen something in that, but can it rule out other things? Because it is used already, isn't it? So does it help rule out things?
Yeah. So the question is, can CSF be used for diagnostic purposes to rule out other diseases? And the point has also been made that its use can be in diagnosis. So first of all, yes, it can be used to rule out other things. It can be very useful for ruling out cancer. It can be useful for ruling out inflammation and infection in the spinal fluid. And it already is in use for aiding the diagnosis of Alzheimer's disease. So we expect to see a drop in the A-beta protein in Alzheimer's disease and an increase in tau. And that is of some diagnostic value already. But the question is, are there other markers that might help us to diagnose PCA specifically, for example? Because PCA is behaving very differently from other diseases, so is there going to be a biomarker for that? And that's one of the questions that I'm very interested in.
Can I just ask what you said about investigating smell? I presume you mean sense of smell.
That's right, yeah.
And the only reason I ask is because I just happened to notice that Rob's sense of smell is still very sharp. And I just wonder where in the brain, like the scheme of things, the sense of smell is.
So the interest in sense of smell has come from research done in Parkinson's disease, which we've noticed that people's sense of smell deteriorates many years before they ever develop symptoms. And as far as we know, that's due to abnormal proteins forming in the part of the brain directly behind your nose, in fact. And while there isn't any direct association with PCA or Alzheimer's disease at the moment, we feel that we should collect this information because we don't know what we're going to discover. So we're collecting lots of information in lots of domains that might turn out not to be relevant. If we don't collect the information, we're never going to find out. So for example, we are collecting urine in everybody. At the moment, there is no association with urine and Alzheimer's disease or anything like that, but we really feel that it would be useful if in 10 years somebody identifies a biomarker, we've not tested for it, we missed a trick. Aye.
Are the samples kept then? I mean, are there samples from years ago? I mean, certainly David had a cerebrospinal fluid test done because he's got ankylosing spondylitis and the chap working at the Hamptons into his back to get it in 2007. So is that sample thrown away, or will we be able to look back on historic samples from patients and this done as part of your research?
Very good question. So the question is, can we use retrospectively collected samples for research purposes? Well, this is an ethical question which I have been battling with for the last few months, because there is an ethical issue of using samples that didn't have research consent at the time. People didn't give consent for research at the time. So I'm trying to argue that it's in the interest of people with diseases such as Alzheimer's disease to have the right to use these samples, because they're very precious samples, and pending the outcome of the ethics committee.
It's about how long they last biologically. Do they deteriorate or?
So the question is, do the samples deteriorate? Again, CSF seems to stand up the test of time without too much difficulty. So we can keep samples at -80 for decades without them deteriorating. What does seem to be a problem is if you freeze them, defrost them, freeze them, defrost them more than about 3 times, then the proteins seem to be degrade. And the other thing about the timing is that before 2007, 2008, we used to collect CSF in a specific type of test tube, which and the proteins adhered to the side of the test tube, and it gave us confusing and misleading results. So it was only really since 2007, 2008 that we started to collect them in polypropylene tubes. So I would only trust the sample that was taken after 2008.
I was wondering whether actually, in connection to your technical problem, if people who are sufferers, perhaps in the group, made their voice known about their feeling also, it might actually assist you to a decision, because some of these things get terribly bogged down in committed time. I wonder whether perhaps people did show support for the use of these samples, that it might actually carry weight.
Well, I'm very grateful for the offer of advocacy. The Royal College of Pathologists has just published a guideline suggesting how we should use historical samples, and states that CSF is a very valuable sample. So I'm cautiously optimistic that that will be enough to give us the right to use the samples. But it's useful to know that the consensus is that people are for this, because I don't feel it's unethical, and I think we should be doing it. Did you have another question?
If PCA is a part of the brain, after death you can confirm that it was PCA. If you look at a brain, you can say possibly what caused that atrophy. But I still sometimes wonder what this thing called PCA is, apart from a description of something going in a part of the brain. But does looking at the brain after death actually reveal a lot?
So the question is whether doing a post-mortem examination of the brain aids diagnosis. Well, it doesn't. It wouldn't diagnose PCA, because PCA is, well, first of all, not as yet clearly defined internationally, and it is a clinical syndrome, so it's based on what we find when we examine people, and it's also based on the radiological findings, the MRI findings. What the post-mortem study is invaluable for is telling us what proteins are forming in the brain and what at a microscopic biological level goes wrong. And most people with PCA, as you're probably aware, have got Alzheimer's disease pathology, and so they have a combination of plaques and protein misfolding. and it's very, very useful for us to be able to confirm that. So again, post-mortem is going to be something that all our research participants are going to be asked to be involved in, because it's almost the single most useful donation that somebody could give, because it is hugely valuable. And we have these meetings that happen once every month, where people have kindly donated their brains after death. We're able to look at all their clinical findings and their research findings, and then look at their brains and see if we were right. And that's the only way we can get definitive answers. It's hugely valuable.
Can I ask a question? There's one from Skype. The question is there any, do you know anything about the science of Suvanade? Have you heard of that? It's Suvanade? So something that is that something you've come across? Or, sure. So Suvanade is a dietary supplement that has been, I think there's been a study in the US of its use in Alzheimer's disease. And I think it's been shown to have some sort of beneficial effect, but I don't know any details about it. So it's definitely something we should look up and investigate.
That's good. My hands up and say, do a little bit of that.
There's another one here from Pam in America saying, any comment on can you read it? Because I can't pronounce these names. Resveratrol and fruit flow 2.
Okay.
So
So these are
brain pacemaker.
okay. So there are specific drugs that people are asking about, and in order to prove that a drug is effective, it needs to go through vigorous or peer-reviewed trials, and there are broadly 4 stages of evidence that are required before a drug can be commonly used and accepted as having properties where you would prescribe it to people, where we get a license for prescription. I don't know about these specific drugs, which means that they're not licensed in the UK, we don't use them regularly, therefore they haven't passed the rigorous testing that is required. So in short, I don't think there's sufficient evidence to be using these for clinical benefit. And I would always say that if something hasn't passed the licensing board for a particular country, then you have to ask, what are the risks of using that thing? And then also, what are the costs and what are the motivations for people having marketed these? If people are asking you for hundreds and thousands of pounds, then you should really be questioning it. So that would be my word of caution to you.
And the brain pacemaker, I think there was an article in the press this week about it. Do you know anything about that?
I'm afraid again, I don't know.
Thank you.
Did you have a question?
It was just about Suvanade, that it's made by Danone in France, and there are mixed views about it. Some people have had benefits from it. It's like a yogurt, and you can take it once a day or something. And again, it's it's marketed by a company who wants to make money, but it's also helped some people. I was going to ask you about 2 other drugs, but in view of what you've said, maybe I shouldn't. One of which is approved in America and available, called Posifen.
Again,
No.
I don't know about that, and there are a lot of drugs that fall by the wayside, and they just don't stand up to the
But if they are just supplements rather than drugs.
yeah, that's a good point as well, because supplements don't have to go through the same rigorous process.
If it's sort of yogurt, it's not going to do you any harm, and most people eat yogurts anyway, so if you can get
Well, this
of yogurt.
is an excellent point.
Tasty ones.
Make sure it's tasty yogurt. Exactly. Well, if it's not expensive, if they're not asking you for lots of money, and there are no risks associated with it, then by all means, why not try it?
Unless,
Yeah.
of course, you're making money out of it.
Question at the back there.
Have you any proof that Aricept is effective in PCA cases?
So Aricept has got a license for Alzheimer's disease,
Yes.
and we assume that in the original studies for Aricept that there would have been a cohort of people with PCA within that. I'm not sure about specifically for PCA.
Excuse me, on the point of Aricept, some people have been recommended to take memantine as well. Do you know anything about that?
Yeah, so there, again in the UK, the combination of Aricept and memantine, particularly for people who are further on in the disease, has a license. Again, specifically in PCA, there isn't evidence for it. It's for Alzheimer's disease as a whole.
Can you just say
So there's a lady at the back who's had her hand up for ages.
Sorry, talking about Aricept, I understand that in the States, the standard dosage is double what is prescribed in the UK. Do we have any knowledge on whether this double dose of 20 milligrams a day in the States is more beneficial than what the standard dose in the UK of 10 milligrams is? Have you heard that?
I'm not sure the answer to that. I'm not sure. I do know that. As you,
the question, please?
so the question is, in the States they use routinely an increased dose of Aricept compared to in the UK, and whether there's any benefit from that. And I have to be honest and say I'm not sure if there is evidence comparing 10 milligrams to 20 milligrams. Not sure.
Val, should we take the
Yeah,
next
so I
one?
just-
Back here.
sort of following that, at what stage in the disease does Aricept, the use of Aricept decline?
Sorry, do you mind just repeating the last bit?
Yes, at what stage in the disease does the use of does Aricept become useless?
Become useless? Well, again, a very good question. The question is, at what stage does Aricept become useless? Now, if you want me to talk from a public health perspective, I can. If you want me to talk about the perspective of the patients I see in clinic and what their reported experience is, then I suspect that would be more useful to you. We are of the view that you continue for Aricept as long as the GP is willing to prescribe it for, because we think people do get benefit, continued benefit from it. There has been a political move to stop Aricept once people pass a certain stage of the disease process, because there's no proven benefit from it.
I've just had Pam tell us from America that her friend who's taking Aricept is on 10, not 20, if that's helpful from the American perspective.
Okay.
What was that?
Just a story of somebody who's on 10 milligrams in the States.